Hello, welcome to this webinar from the EAPC. I'm David Oliver. I'm chair of the reference group on neurological care. And it's wonderful to see that we have 333 people registered for this meeting. And I can see the numbers are coming in quick and fast at the moment. And we're really, really pleased. It's my pleasure to welcome you, and I hope that you've all enjoyed the various blogs from the EAPC that we've run over this last couple of months on neurological care. There will be a link to that later, and if you haven't seen the blogs, do have a look. The format for this afternoon is there are three of us who are going to give short talks, and then we've got a good 30 minutes, I hope, to have discussion. We've had some questions already come in. If you do have a question, could you put it in the Q&A section? We'll be keeping an eye on that all through the sessions, and we'll come to those questions at the end. We can't see you, you can see us. We'll be very, very pleased to have you here. We've got two other speakers with me. There's Alexandra Solari, who's a neurologist who has a very special interest in multiple sclerosis, who is based in Milan in Italy, and Simona Veronese, who is a palliative care doctor who has been involved in research on neurological palliative care as well, from Turin in Italy. And I'm, as I say, David Oliver. I'm a retired consultant of palliative medicine, but still undertake some academic work and involved in both the EAPC and also, for interest, so you know, we have a very strong link with the European Academy of Neurology. So we have the opportunity to collaborate between neurologists and palliative care. So without further ado, I'm seeing we've got 76 people in at the moment. So I'm going to try and share my screen. I hope everyone can see that. I'm getting nods from the people I can see. I'm going to start with a very short time just to look at how neurological palliative care may be seen. So what happens in neurological disease? There are progressive diseases like MND, motor neuron disease, amyotrophic lateral sclerosis, Parkinson's, MSA, PSP, the dementias. Those diseases, there's progression in the disease, they're disabling, there's usually no curative treatment, and the treatments that we do have may slow progression, may help with symptoms, but we know those patients are going to deteriorate and die. There are other diseases. Multiple sclerosis has changed dramatically over the last 20 or 30 years. There are now many disease-modifying treatments. But even with those treatments, there is a variable progression and a variable prognosis. There are diseases like stroke, and stroke's just become a neurological disease in the official classification of diseases, where there may be a sudden death. So you may be faced with a family who is suddenly seeing someone who was very well one day, who is very disabled and dying the next day. There's that progressive disability that may occur, and also uncertainty. And then there may be people with brain injury, which again will be very uncertain. I think there are some specific issues within neurological care. There may be the genetics, and the obvious one is Huntington's disease, where patients are facing knowing that they have the gene and 50% of their children may be affected. So it's a real problem. I remember I had a patient whose memories of Huntington's disease was visiting her father, who'd become very aggressive, had been admitted to a long stay psychiatric hospital, and they visited every Sunday as he deteriorated and deteriorated over years. That was her memory of Huntington's disease. But she was also facing the fact that she knew her son was positive for the genes as well. So she had her own disease, but had the memories of before and have fears for the future. With Parkinson's disease, there's the movement issues. With multiple sclerosis in the longer term, incontinence and cognitive change. And as I said earlier, with stroke, that uncertainty. Am I going to have another stroke? Am I going to get better? Now, the EAN and the EAPC 5 years ago, and this is open access, so anyone can see it if you'd like to look for it in the European Journal of Neurology, said we looked at a consensus document on palliative care. And we said palliative care should be considered early in the disease trajectory, obviously slightly depending on the underlying diagnosis. And we are looking, as we would in any palliative care setting, we're looking at physical issues, the symptoms. There are the other issues of positioning and mobility. And I'm sure any of you have looked after someone with MND ALS knows the difficulties of getting someone in a comfortable position. The nurses have spent an hour doing that. They leave the room and the buzzer goes, "Can you come and move me?" The issues of communication. Do I understand the person who's speaking? Or are there cognitive changes? But they're the psychological and emotional aspects, the social and the spiritual. I'm not going to go into depth in everyone, but the symptoms, these are some of the symptoms that are common. Many different symptoms, I think, is the most important. We need to remember that patients will have symptoms, and we may need to ask very, very carefully, and in that assessment, are they telling us all their symptoms? Are they embarrassed about their incontinence and not talking about it? And with psychosocial issues, I think the patient is facing multiple losses. They're the physical losses. They lose mobility, they lose speech, they may lose their breathing abilities, there may be cognitive changes, there may be emotional changes. The person with emotional labidity, cerebral palsy, who cries in what seems to be an uncontrolled way or laughs in an uncontrolled way. Patients hardly ever tell you about that. If I suspect it, I ask, and a look of relief comes over the person's face because they didn't want to talk about it because they thought they were going mad. To actually explain it's part of the disease, such as in MND ALS. There may be fears of the disease. People know about cancer. They know how someone with cancer may be. They've had someone in their family. They may never have heard of ALS. They may never have heard of the disease. Or, in the case of Huntington's, they only know too well about the disease. There is another issue that I think in many countries, and certainly in the UK, the debates about assisted dying, about euthanasia and physician-assisted suicide, often involve people with neurological disease. And so people hear about the distress of dying with a neurological disease. There's more and more evidence that does not have to happen with good palliative care, but it's there in the newspapers and the media. A few years ago, we had a person with ALS asking for assisted dying who said, "I don't want to be tied into a wheelchair with saliva dribbling down my front until I choke to death." And that was very hard for patients who've been newly diagnosed to suddenly read about. I think there's the fears of death and dying that anybody may have, but specifically, is it going to be a distressing death? And again, I can say, I think the evidence is more and more that it's more likely to be distressing with a neurological disease than any other disease. Within a family, there are many changes. The role changes. The person who's disabled, who can't do their role as perhaps getting money and being the wage earner, or looking after the children, or whatever the changes that happen. There are losses. The person loses the patient if there's cognitive change. I'm sure you've had patients who have seen talk to their husband or wife with a cerebral tumour or dementia and say, he's not the same man that he was when I married him. There's changes within the partnership. They have their own fears of the disease. There are often financial issues. This will vary country to country of how much support people have. But for someone who has to give up work, and then their partner and their family have to give up work to look after them, there may be big financial issues. They have their own emotional changes and having to cope with. And I think that also includes intimacy and sexuality. Do we ever talk about that in palliative care? I think we're quite good at talking about death and dying, but not so good about talking about intimacy. I did a short survey of patients with ALS many years ago, and one man said, thank God that's not a muscle, because that's still working. And there was a wife who said, I do not know what I am when I put my husband to bed. Am I his lover and his wife, or am I the nurse? And then their fears of death and dying. And connected with all of this is the spiritual existential aspects. And if anyone is particularly interested, I would recommend the paper by Gofton, because it's not necessarily religious aspects. It's the distress from the loss of function, of the loss of communication, of cognition, perhaps the loss of autonomy. I can't make any decisions now, and the fear of death. And that may be religious, but it may just be any of the team just need to listen and hear those aspects. And I think often these are the aspects that come to the fore when someone talks about hastening their death because of that general distress. And Gofton in that paper also talks about the existential distress for the carers, for us as professionals, that we feel impotent, that we can't always have an easy answer for a symptom. There's no easy way if someone's lost their mobility of making it better. And there may be fears of dying and death. And I'm sure, as you all know, in palliative care, we need to make sure we talk about the right one. Is it about dying or is it about after death? And we need to separate those and find out what really is concerning someone. So it is a multidisciplinary approach. It's a multi-agency approach. But we need to make sure we coordinate that. I know when I used to visit a patient with ALS at home, I'd ask what's happened, and the person would say, well, I've seen this person in a blue uniform, someone in a green uniform, someone with a big diary, someone with a bag of food. You've come as a doctor, I think. I don't know what's going on. All these people have come in, but no one's talking to each other, and I'm saying the same things again and again. That we don't overwhelm patients, and we need to remember the support of carers. That's not just us as carers, but the day-to-day carers. I did a small survey when I looked at patients with ALS we'd been involved with. And at the hospice, I had seen some patients 10 or 12 times over the year or two we'd been involved. The physiotherapist had gone 20 times. And we suddenly realized that the carer who was looking after the person at home would come in the house in the morning, at lunchtime, in the evening, every day for 6 months. And when that person died, the next morning they were moved to somebody else. And no one really ever remembered how they were. It is multidisciplinary team care. And I think there's increasing evidence that that's helpful. In the UK, we had a National Institute for Care and Health Excellence guidance looking at ALS, and it recommended the multidisciplinary team approach. And it said within that, palliative care expertise should be there, either as one of the team members with that expertise or with someone coming from the local team. And there is evidence that multidisciplinary team care does help. There are 2 surveys now. There are arguments, there may not be, the comparison is difficult, but the groups that had the multidisciplinary team lived longer. Not only was their quality of life better and their symptoms easier and they felt supported, but they lived longer. And that was independent of other treatments. There's some magical aspect of a multidisciplinary team. And when I look back, I think it's because everyone is talking to each other. So the speech therapist can come back and say to the occupational therapist, I saw the person yesterday, they're swallowing all right, but they can't move as well. Can you help with that? And everyone is talking together. And then when we get towards end of life care, do we anticipate it? Are we aware of it? Are we making sure symptoms are well managed? Are we communicating that to family and carers and team? Are we supporting everyone? And may we have some quite complicated ethical decisions like the withdrawal of ventilation. And that consensus document stated very clearly that the recognition of that deterioration in that last weeks and months was really important, because that allowed us to manage appropriately. Are there interventions we can stop or ones we can need to start? Are there medications that we can now stop or to have quickly available? Are we supporting carers and families? And within our NICE document, we said at the end of life, families need to be families, not just very over-involved carers. So families can sit back and people can do the care and they can be there as a family member. And we need to have that discussion about end-of-life care all the way through the progression. And it may be even at the time of diagnosis, someone will ask, what's going to happen to me in the future? I've read about choking to death. Is that really going to happen? And particularly as we have changes, we need to be looking at that again. And we'll be talking about advanced care planning shortly. And I think neurological patients, we have this added complication in many ways that we have people who may lose their cognition and may lose their communication. So we may have to have these discussions slightly earlier than they would like and we would normally think about. Because if we leave it, they won't be able to be involved in those discussions. We need to have that open discussion about dying. And if someone talks about hastened death, even if we're in a country where that's not possible, we need to listen and see what's behind that. When might we think that someone is actually getting to the end of their life? This was a small consensus decisions that were suggested and are used in other, like the gold standards frameworks or SPICT, if you've heard of that, and other systems, which we'll be talking about a little bit later. But is it the patient request, the family request? Someone with increasing swallowing problems, increasing breathlessness, their cognition is declining, repeated infections, particularly aspiration pneumonia. And Hussein undertook a study where they looked at these triggers and found that they increased as you got nearer to the end of life. And the one that increased most was aspiration pneumonia. And aspiration pneumonia means you can't cough, you can't breathe, you can't swallow very well, and is a real indicator that someone may be entering the last few months of life. Is it weight loss? Is it that gut feeling we have? So we need to be thinking all the time. And we need to think about carers. Are we assessing carers? Are we supporting them before and after death? Do we support professionals? Through education, through support, through supervision. I'm sorry if you heard me say this before, but doctors in the UK have no problems with stress. But we have a very high divorce rate, a very high alcohol rate, drug abuse rate, and suicide rate. But we cope with stress. We're not very good. Do we support each other? And I think that's one thing a multidisciplinary team can be very helpful with. I think Simone will be talking a little bit more about some of this later, but do we have a variable palliative care input over a period of time? And for someone with ALS, MND, this whole line at the bottom may be 2 or 3 years. For someone with Parkinson's disease, it may be 10 or 15 years. But there are times when there are particular needs. So with the person with ALS, at diagnosis, what's this all mean? Are the problems with swallowing a few months later? Problems with breathing a few months later? And then a year or so later, the person is dying and continuing into the bereavement and supporting family. And one way of seeing when those peaks may be happening is if we use assessments, which we'll be talking about later. And is this effective care? There is increasing evidence that for neurological patients that there can be improvement in quality of life, in symptoms, particularly in one survey, pain, sleep, breathlessness, and bowel problems, with emotional issues, social issues, spiritual area, and interestingly, non-religious in that area, in carer support. And perhaps very importantly was the death rate in nearly all these studies, that the death rate has been similar in the palliative care group and the control group. So it isn't, as some neurologists may fear, if I refer to palliative care, they'll all die very quickly. They actually, as we've seen, probably live longer, and it's certainly not going to cause their death. And there's some evidence that it's cost effective. So what's the role? It may be from diagnosis for severe stroke or ALS. It may be times, as we said, through the disease progression with some of the neurodegenerative diseases. And at the end of life, all neurological patients, I think, are appropriate for palliative care. And we need to develop that collaboration, that understanding of roles, that contact from early in the diagnosis, particularly towards the end of life, and educate all involved, because our aim is to improve the quality of life and the quality of dying. But I think I've said it earlier, but to actually talk about someone about their spiritual issues at the end of life is where you've only met them when they're communicating with a communication aid, is very difficult, which is why earlier is better. And where does specialist palliative care come in? With complex issues, perhaps with the ethical issues, with advanced care planning we'll be talking about, and bringing in that palliative care multidisciplinary team approach. I put some references here if you're particularly interested, and thank you very much for listening. What I'd like to do, I'm just going to double check if there are any particularly questions for this. Looking very quickly, it looks as if perhaps we could take questions all together at the end. And I think that will probably be the more sensible way of doing it. So I'd like to pass over to Alexandra now, who is going to talk about palliative care and multiple sclerosis, how we have the European Academy of Neurology guideline, which the EAPC was very much involved with as well. So over to Alexandra in Milan.
Thank you, David. Thank you very much. I share my presentation now. Okay. So let me try to see if it works. Multiple sclerosis, after the introduction from David, I don't have to spend many words on this condition, which is one of the most common causes of disability in young adults, and people with the progressive form may live with complex needs for several years, sometimes decades. The EAN guideline on palliative care of people with severe multiple sclerosis is a joint initiative of the EAN, the EAPC, the RIMS, and it has been also endorsed by the ECTRIMS and by the MSIF, which is an umbrella organization of national multiple sclerosis societies. We use the GRADE method, which is considered the gold standard in guideline production. You see in this cartoon the different steps, the different phases of these methods, which starts from the formulation of the clinical questions, which are relevant to the stakeholders. The questions are formulated using the PICO framework, which means population, intervention, comparator, and outcomes. And the guideline panel decided to involve stakeholders in this very important phase of the guideline by conducting an online survey which involved more than 1,000 patients and caregivers from all over Europe, and also involving health professionals dedicated to multiple sclerosis. And after this consultation, the panel formulated the clinical questions, which were 10. Here you see the clinical questions, which are reported only for the I component, so the intervention. 2 of the questions are on palliative care, general and specialist palliative care interventions. 1 question is on advanced care planning. 1 is on discussion with health providers of the patient wish to hasten death. And I would like to emphasize that these very clinical questions was formulated by the panel, but it was proposed spontaneously by the patients during a focus group meeting. Symptom management, multidisciplinary rehabilitation, interventions for caregivers in terms of training in caregiving and practical and psychological support to caregivers. And 2 questions were on training of health professionals, which means professionals dedicated to MS who have to be trained in palliative care and vice versa. From these 10 clinical questions, we formulated 34 recommendations. Most of these recommendations were on symptom management, and also 7 good practice points as from the GRADE method for those questions for which there is no evidence available by searching the literature. The panelists can decide whether to abstain from giving any recommendation or providing a good practice point statement. And within the panel, we decided to go this way because clinicians need advice and suggestions on how to move, and it is important to provide recommendations which are based, in the case of a good clinical practice point, on consensus within the panel. The guideline was published in 2020, and as it often occurs for guidelines, there was a publication in the Journal of Palliative Medicine and the same publication in Journal of European Neurology in order to disseminate the guideline. And these 2 societies, as I said, were 2 societies who partnered the initiative. I will go very shortly on the recommendations starting from the first two. We formulated one recommendation regarding palliative care intervention, and it says it is suggested that home-based palliative care is offered to people with severe MS, either as general palliative care or as a specialist palliative care. This recommendation was based on 3 randomized controlled trials, and it was possible for symptom burden and for caregiver burden to perform also quantitative synthesis of the data via meta-analysis. We also formulated a good practice statement. It is suggested that inpatient or outpatient palliative care is offered to patients with severe MS. In this case, we didn't find any evidence on inpatient or outpatient palliative care intervention. And this is the reason for having a statement instead of a recommendation, as all the trials were on home-based palliative care interventions. Another clinical question was on advanced care planning. And in this case, we didn't find any evidence of efficacy of interventions. We produced 2 statements. It is suggested that early discussion via EAPC is offered to patients with severe MS. It is suggested that regular communication about the future progression of MS is undertaken with patients and the families. And I think that these 2 statements describe quite well advanced care planning as a process and not as a single happening event. The question on discussion of patient wish to hasten death produced 2 statements, and we didn't find, in fact, any evidence on this clinical question. And you see here the questions. Patients should be encouraged to discuss their wishes about future care. And the other one, healthcare professionals should be aware of the risk factors for the wish of hastened death and encourage the sharing of these issues and the appropriate management. In many cases, it is important to see what we can do to improve the quality of life of these patients, to see what is the reason of their suffering. And sharing these discussions and these feelings is quite crucial. Symptom management, MS, as David described before, is characterized by the presence of many symptoms. These symptoms are present in a variable combination in the single patients or in different patients a long time. And we found many studies on symptoms management. Unfortunately, on some symptoms, we didn't find any evidence in this very population of people with MS in the severe form of the disease. We produced 29 recommendations on spasticity, fatigue, pain, and bladder problems. And overall, we found 43 randomized controlled trials, and we were able to produce a strong recommendation on the use of namixibols for spasticity, which means that on this drug there was quality evidence, and there were many trials, and we could produce just one strong recommendation that was on this very treatment. Multidisciplinary rehabilitation is important in people with progressive multiple sclerosis, and also, of course, in the severe form of the disease. And here we produced 2 recommendations based on 8 randomized controlled trials and on 1 clinical controlled trials. And the 2 recommendations regarding the use of multidisciplinary rehabilitation and to use these intervention in inpatient, outpatient, or as an home-based treatment, depending on the setting and on the preferences of the patients and the family situation. 2 questions were on caregivers and interventions directed to caregivers who have an important role in the care of people with severe MS. And the 2 recommendations, both of them, were based on a single randomized controlled trial, which was published about 20 years ago in the US. This study had a long follow-up of about 2 years, and the first recommendation is it is suggested that caregivers or patients with MS are offered education and training programs on caregivers. It is important to train caregivers of MS patients to their caregiving role. But it is also important to offer caregivers practical and emotional support, as their role has an important impact on the quality of their life. The last 2 clinical questions are on the training of health providers. And as I said before, we had 2 questions and 2 statements which were produced on these 2 questions, as we didn't find the evidence of interventions which were of proven effectiveness. The first statement is it is suggested that the principles of palliative care are included in the training and education of neurologists and the other health professionals involved in the care of MS patients. And the second is it is suggested that the principles of MS management are included in the training and education of specialist palliative care professionals. So what is the message from this guideline? There are 2 strengths in the guideline. One is the method we used, that is a method that helps to trace the process that the panel used. The consensus is a guided consensus. And the second strength is that we involve the patients, the caregivers, and the health professionals in our activities by this consultation, which took about 1 year to be completed. So it was quite engaging, but it was worthwhile. And we also had 1 person with MS who was part of the panel and who was very active during all the period in which the panel was actively working. Unfortunately, of the 34 recommendations we formulated, only one was a strong recommendation because the evidence was not so qualified for the remaining studies. We provided some indications for research, and this is one of the aspects that are important in a guideline. So to highlight what is missing, and there are several questions that need more evidence, such as interventions to improve advanced care planning, the management of fatigue or depression in patients with severe MS, and interventions, for example, for caregivers and health professionals. And last but not least, the importance of integrating palliative medicine, neurology, and rehabilitation in the care of this patient population. It is really quite important that these disciplines are integrated. After the guideline was published, evidence was published, and I would like to mention briefly the clinical trial from Buzgova et al. From the Czech Republic, which was again a trial on a home-based palliative care intervention for people with severe MS and their caregivers. And the OptiCare Neuro trial, which included many people with MS, about 1/3 of participants had this disorder. And also a multi-center trial on a home-based standing frame intervention, which was conducted in the UK. And this trial showed how a simple intervention can be very effective and also cost-effective to improve the mobility of people with severe MS. And caregivers can be easily trained to administer the program to their beloved. And finally, also an ongoing study on ACP in people with MS that we are conducting in Italy. And finally, I would like to thank the panel of people from different parts of Europe who were actively engaged in this guideline. And David and Simone were part of the panel. Here are some people who were, and this picture was taken at the beginning of our activity. And I would also like to thank the EAN and the RIMS and the Italian MS Society, as they provided also, they supported economically our activities. And thank you very much for your attention.
Thank you very much indeed, Alexandra. And as someone who was involved, I don't think everyone can quite imagine the amount of work that goes on to undertake a review and a guideline like that. But it is very important. And it was, I think, one of the first times we've managed to get the publication in a palliative care journal, the Journal of Palliative Medicine, which is associated with the EAPC, and with the European Journal of Neurology, which is the EAN's journal. So that was a really important point of trying to get it to neurologists and palliative care specialists. Thank you very much indeed. So we'll move on now to Simona, who's going to talk about patient assessment.
Thank you, David. Thank you, Alessandra. Thank all of you for being here. I'm sorry because David told me that probably my face is a little bit dark, but it's the highest luminosity I can have in my studio. So I'm sorry for that, but I hope you can hear my voice, which is more important, I hope. So, and thank you very much for setting the scene for this presentation. I just want to start by saying, why are we talking about needs assessment? Why is it so important? If we look at one of the first definitions that we had in palliative care that was published on the WHO website, now we have a new one, but I think this remains important. And you know, the aim of palliative care remains the quality of life of the patients and their families. And to get there, we need to go through an early identification, and you see an impeccable assessment of their needs. So this is what we are required to do in order to be able to help the families and the patients in the journey of the disease. And this is about all palliative care, not only neurological care, but it remains fundamental for what we are asked to do. So this is a part of our goal. So we need to understand how we can, impeccable maybe is too high, but to be as good as possible in assessing the needs of the patients. And Dame Cicely Saunders stated that in the first year of the St. Christopher Hospice activity, they looked after people with Parkinson's disease and ALS. So the relationship between neurological care and palliative care is from the beginning of modern palliative care, but the problems were there as we are facing them now. And in order to, David talked about the importance of assessing the needs in the multi-dimensional way. And when Dame Cicely Saunders talked about total pain, so total suffering, she already mentioned that the big dimensions that we have to look after. So the physical one, which are the symptoms mainly, the psychological, the social, and the spiritual. So if we want to assess the needs of patients suffering from neurological disorders, we have to keep in mind these 4 dimensions. Maybe we need to go even further. We discussed about the importance of choices and so on, but this is a kind of mainstream we have to follow if we want to assess properly the needs of patients and of course of their family. So we are on track. This is palliative care. So, and our colleagues from the York and Hull Medical School, in particular Felice Mertag, talks about the relationship that there is between needs assessment and outcome measurement. Because we all know what needs assessment is, so we want to go and ask and understand what is the causes of suffering and how we can define it. But if we use a need assessment tool, or maybe more than one, and we rigorously repeat it over time, depending on, and we will see when and how and who is supposed to do it, and we compare the results of different needs assessment, trying to understand the difference that was made by the input of what we are doing, so of our service as neurologists, palliative care professionals, rehabilitators, and so on, and we can measure the difference, then we are measuring an outcome, the outcome of our intervention. So Felice Mertag invite all of you to check on the website where they have a lot of videos and very interesting tools to go further than what I can tell you now. And she asked me to tell you, if you go there, please check on at the end of the list of the website where you can access as an external professional, both if you are from the UK or international one. So go there and check their very important content. I will try to say something about that, but over there you can find more. So typically an outcome in medicine can be defined as the change in a patient's current and future health status that can be attributed to preceding healthcare. So what we do that change something important, and you know, the main outcome in palliative care is quality of life, but then we have to enter into the big concept of quality of life and see the difference that we can make in physical, psychological, spiritual, social issues, and so on. But normally we tend to associate outcomes in research, which is very important, and also in quality improvement. But now we will talk in this talk, I will talk about the clinical care. So how we can use outcome measurement to improve the quality of care for a patient, okay? And that's not so straightforward. Often we think outcome measurement when we think in randomized control study. It is very important, but now we want to see how needs assessment can be helpful to improve the quality of the care that we are providing to our patients and their loved ones. And the EAPC helped us a lot with this publication that is still available and very interesting, how to choose a proper outcome measurement in palliative care. So in this publication, you can find a lot of suggestions on the characteristics of different outcome measurement. And Professor Irene Higginson, that of course developed a lot of outcome measures, summarized these important tips in this one that you can see. So an outcome measure should be clinical relevant, including all the relevant domains. We already talked about the multidimensional importance of suffering. But the same outcome measurement, the one that we use in clinical practice, must be appropriate and acceptable. So the question that we ask must be appropriate. For example, there were some in the past and still are available some questionnaires asking, for example, people, do you think your life is still worthwhile? This can be a very important question, but sometimes it's very hard. For example, in our culture, I'm talking about in the Mediterranean culture, it's very hard to ask a question like that. So maybe you want to explore that dimension with a different question, for example. An outcome measure must be validated. What do we mean by that? That we must rely on it. So depending on the results of the needs assessment, I can change the way I will change the plan of care, because I trust it as I will trust a thermometer or another medical tool that will give me important information. It must be stable, reliable. So all these characteristics are in the paper that I'm not going into now. And it must show clinical relevant changes. What does that mean? Sometimes we use scales only with numbers, but we are not sure if maybe passing from an 8 to a 9 or to a 67 to a 71, does it really change something in the life, in the quality of life, in the experience of that issue, in that problem? We don't know that. So we need outcome measurement to give us very important, in order that we know if that is clinically important for that patient. And finally, it must be brief, because we don't have time. Time is a very scarce resource for us as professionals, and at the end of life, is a scarce resource for our patients. So we don't want to waste their time in clinical practice with very long and burdensome outcome measurements. So we have to bear in mind these characteristics are very important if we want to use, and I of course recommend to use, outcome measurements and needs assessment tools in clinical practice. So again, our colleagues from the Hull Medical School tells us that in using outcome data in clinical settings can provide very important for the single patient, but also for a cohort of patients that we are looking after, for example, in our palliative care service, in our neurological service, if we use them with the patient. But we can also use them far from the patient to discuss, for example, in a multidisciplinary team of the issues that were assessed with an outcome measurement, for example, and maybe exchange this with other services, maybe in network of care. David talked a lot about collaboration. So can you imagine if we could share the results of good needs assessment between neurologists and palliative care in order to see when it is important to have an input, for example, because we think we can do that depending on the quantity and the quality of the needs that have been assessed in a different service, for example. And then can be used, of course, when we want to present our reports. Maybe we want to go to our politicians saying that they want to pay us, and say, okay, because we are able to show you that we improve the quality of life of our patients, we improve the symptoms, we improve the psychological and so on. So there are many points that we can use properly outcome measurements in clinical settings to improve the quality of care of that patient, of all patients, and maybe of a lot of patients if we think in a national, for example, way. So moving on, but using outcome measurements improve the quality of life of our patients. Well, this paper tells us it is a systematic review, sorry, showing in the literature that there is a positive effect on patients, on highlighting symptoms, on monitoring symptoms, on starting new actions based on the real needs of the population, on improving the satisfaction of care. And, it means that this is strong evidence. So it means that if we properly use outcome measurements in our clinical practice, we really are better in taking care of our patients. So I think this This is one of the main messages I would like to give you in my talk. What is important for patients when they are receiving palliative care, when they have palliative care needs? So we're not just talking about end of life. We're talking about through all the trajectories of their diseases, to have their own priorities recognized and received. They want to know they want us to know who they are. So what are their priorities? This is a concept inside the, and Alessandra is very good at this. When we talk about shared decision making, when we talk about goals of care, we need to know the patients, and we want them to know that we are interested in them, even when sometimes it's out of our care, because it's starting a good relationship, and after that, probably. And so for them, it is important. And of course, it's important to have relief of their physical symptoms, to feel that their loved ones are relieved by the burden of care. Can we do something to make the burden of care less important? To help them to feel at peace, to cope with losses. David talked a lot about spiritual suffering, existential suffering. Can we do something? Well, we're part of care. We need to assess that and see if something can be done. And of course, we don't want to waste their time. So if possible, to coordinate services, and again, cooperation, multidisciplinary teams, it is a way to reduce the time that they have to spend to coordinate the services they really need. So this is important for patients at the end. It's not the only thing, but And so what can we do? First of all, we need to identify the patients who need palliative care. And we have a lot of tools. For example, this is they call the framework tool, but there is the neckball, there is the RADPAC, there is a SPIT, there are many of them. But the important is that we know them and we apply them in order to see, okay, this cohort of patients, neurological patients, may have palliative care needs. And all can start with a surprise question. Would I be surprised if this patient were to die, but not only to die, to deteriorate? To lose cognitive functions, to lose communication functions. So if I think, no, I wouldn't be surprised. Well, I have to start to assess their needs, which is what we're talking now. Because after having identified the patients, and we have these tools that can help us, we need to assess their needs. And at that time, we need to start to plan their care based on their needs. So this is another clear message that I would like to give you. I'm not talking about this tool in particular that was developed in the UK, above all for the primary care, but it can be used in neurological care as well. If we follow, this algorithm of thinking, and then when we have identified that, maybe we can discuss it with our colleagues, with nurses, with our professionals. Do you think this patient might have palliative care needs? Yes, okay, let's assess them. We have the tools, and then we can see if we maybe need a palliative care input. And we have also practical suggestions on how to use significant outcome measurements in clinical care. For example, the O collaboration from the R&D Dickinson Center, the King's College Group, the Cicely Saunders Institute, put together a number of outcome measurements that can be used. And I'm just talking about three of them, the core of them. IPOS, which is probably, we will see the most modern outcome measurements in palliative care. There are others that are very good, but this one is the one they use, so I will talk about that, just to give you an example of its property and how we can use it. And then a palliative care phase and a good measure to measure the performance status of patients. There are others, for example, for carers as well, are very important. I don't have time to discuss them, but you can go there in their website and see what they propose. So this is the IPOS. IPOS is the Integrated Palliative Care Outcome Scale. It's the last version of previous outcome measurements. Some of you will be familiar with the STARS and then with the POS and all the symptoms, different symptoms modules that they have on the POS. So they integrated the symptoms into the POS, and now we have the IPOS. The IPOS is very good because it contains all things that are important that we discussed earlier. So it starts exploring the priorities. So what were your main concerns and problems? Which means, who are you? Maybe you can talk about things that are not concerned or related to clinical care. You can talk about your football team or maybe your pets or whatever. But it means this is important, and it's not necessarily that we can do something. But you're talking to me before I'm asking you if you are well or unwell, if you're in pain or not. Tell me what is important to you. Is there something that is worries for you, and maybe we can discuss together. And then we go through a number of symptoms. These are just 10 symptoms. So these are not specific for neurological conditions, but the research shows the 10 most frequent, so most prevalent symptoms in all conditions that go to palliative care, so even neurological ones. So it is very probable that inside you will find some symptoms that your neurological patient is suffering from. And if they're not enough, you can add 3. So you have 3 more symptoms that you can just ask the patients and you can measure. And what is important to this tool is that the different scoring of the IPOS means something clinically important for the patient. So for example, a patient who tells you, well, I have a shortness of breath and it is moderate, but after a treatment that you provide, it becomes just slightly, it disturbs slightly. It means that it improved. This is an outcome that of course will be after what you have done, because it wouldn't have it improved just by the trajectory of the disease. So it is very helpful in understanding the quality of care we are providing, and it explores also psychological issues. There are a couple of items talking about a family. So again, we are looking after the family. So this is not a tool to assess the family needs, but it gives us a lot of information, because it asks the patient to tell you, how do you feel they are? Are they worried for you? Can you share your feelings with them? Because if you cannot, maybe we can do something for that. We have, psychosocial care for that. And there are also existential, exploring with just one question. Have you felt at peace? Because that's an important concept. Inside, when you are at peace, you don't have rage. And maybe you don't have a lot of, all the things that David talked about earlier. Because if I'm worried that I will choke to death, well, I'm not at peace, obviously. So it's an open question, but patients are very good at understanding that. They will tell you, and maybe they can ask you, I don't understand exactly what do you mean. We're not at war anymore. Well, we're not discussing about that. And you can also, but it's very useful in clinical practice. And then you have information. So did you receive all the information you need? And again, a question exploring practical and social issues. So of course, this is not exhaustive, but it has all the properties that we discussed earlier. It's very good in clinical practice. But if you are working, for example, in a neurological service and you want to have something more specific for neurological conditions, well, I'm sorry, this is the staff version, because IPOS exists for the patient version. You ask the patient whenever the patient is able to answer, so it's cognitive good enough, or maybe can communicate. But if it cannot, and it happens, of course, in neurological conditions, you have a staff version. Same questions, but from a professional point of view. And you can include the family caregiver into that. So we don't have a specific version for carers, because they saw that it was the most biased one. But we can include the family carer into the staff to say, well, let's look at the problem of the patient in the last week, for example. What do we think altogether that were his or her main worries or symptoms or issues? And then we can decide which of them we will put into our plan of care. So IPOS is free, is validated in all populations, so can be used in neurological conditions, is multidimensional, is able to detect significant changes over time. This is so important in order to measure the outcomes. It is brief. It takes 7 to 10 minutes. I hope you use 7 to 10 minutes to assess the needs of the patient whenever you assess them. It's a very limited time, okay? It can be used in all settings, so you can use it in outpatient clinics, in a hospital, in a hospice, in home care, in care homes, wherever it is useful, you can use it there. Can be used even for patients who are not competent, as we said, and it's free of charge. You just have to register to that and to that website, and then you can download the version that fits most your needs, depending, of course, on the service you're in. But as I said, they also developed specific symptom lists for neurological patients. So these are not for specific diseases, as they had in the previous version. You had a version, for example, for multiple sclerosis, one for Parkinson's disease, but it was so difficult to develop one for all the conditions. So they validated 2 versions, a short one with 8 items and a longer one with 24 items, all symptoms that can be embedded into the IPOS. So you can substitute the symptom list if you don't like it, and you can use them. These are specific for neurological conditions. Again, it doesn't mean your patient has to do it, but probably you can find inside the physical symptoms. And then there are all the other domains of the IPOS that we already discussed, okay? So there is also another version, which is for care homes. This is specifically developed for dementia patients living in care homes, where the staff is asked to pick up what has been the main person, the main problems of the person living there, but also of their family care, because probably they are not there. And above all, in this time of COVID, it's very difficult to have them. So this is very important. And after having explored the main concerns and the main worries, you have a number of symptom lists. And these symptoms, there are some that are specific for dementia, for example, that are not included in other version of IPO. So if you're working in a care homes, if a lot of patients you're looking after have dementia, this can be a very good tool for you. And this is validated. Some of them, for example, the IPOS is validated in numerous languages. For example, we translated and validated in Italian. Others are not yet. So, but in the website, you can find if your own languages is included in the list. And if it is not, well, maybe you can think of starting a relationship with your authors and maybe think of translating and validating in your language, which is very, very important. Okay, so moving on. Last two tools that I'm talking about, and then I will finish, so we will have time for question and answer. As I said, is the Australian version of the Karnofsky performance status. We all use in palliative care the Karnofsky, for example, but we know that the Karnofsky was validated just for the cancer population, and it wasn't specifically developed and validated in palliative care in general. So of course it provided a lot of information, but the Australian people, they validated and changed some of the items for the palliative care population. And so this is valid also for neurological patients. It's not disease specific. So this is why they included into the OAK. It is included into the PCOG, which is the Australian version of the OAK. These are just a suite of measures that can be used in clinical practice and can be very informative and help for what? For a good plan of care for that patient, okay? So what does that tell us? This is the way I interpret it. The amount of care they need and the risk they have in front of them. So of course, if a patient is able to care for most needs, well, probably the need of care will be low. But when a person is in bed for half of a day or maybe almost completely bedfast, how much care do they need? So how can we think to integrate it in order to understand if maybe they need a care at home, or maybe they need a respite care? So this is very helpful, and it is a common language that we can share with neurologists. I'm talking as a palliative care physician now, in order to assess the patients, because in neurology there are many specific tools like that for different conditions. We have the EDSS in MS, we have the ALS-FRS in motor neuron disease, we have the RON-IR and others in Parkinson and so on. They are very helpful because they help neurologists in following up the patient, and they talk about the severity of disease. But we're talking about their needs. So probably this kind of language is more helpful in terms of needs, okay? And so it is another important tool to be used with, for example, an IPOS or other, because I didn't talk about the ESOS PD rather than the POS PD. There are specific, but they are again specific for different conditions. We want something that can be used widely in neurological conditions, because otherwise you always miss the one when you have, oh, this patient has MSA, where is the module? I don't have it. So if you have an overall one, of course it is easier. So the last tool I'm talking about is the phase of illness. Phase of illness is a very, very important tool. It is very easy. We have 5 phases. And remember, these are not phases of depending on where the patient is. It relates to the plan of care. So the plan of care that we put in practice is able to keep the situation stable. So what does that mean? Maybe I'm seeing this person like 3 times per year because I'm a neurologist, I'm just following up. I'm not changing anything because it's good. Anytime I see this person, I go on with a need assessment, nothing changes. Symptoms are in control, family are coping, this patient is not distressed. We don't have to change nothing. This is a stable situation, okay? So this is the aim. It doesn't mean, of course, the disease went away. It's still, of course, a patient with its problem. And you can be stable, maybe with a very low Karnofsky status, but everyone is coping. We don't have to change nothing, okay? But when the phase of the disease changes into unstable, what does that mean? That quickly something happens that we need to reassess the patient because new symptoms appear and very severe, so you need to do something in 1 day or two. Because if you don't do that, the patient will be admitted to the hospital. You risk to lose the patient, and maybe something wrong can start. Okay, and it can be related to the symptoms of the patients. Maybe the therapy that it is prescribed that it can be helpful. Maybe in some crisis, like say the patient can have nausea, shortness of breath. That has always worked. It's not working anymore. So I need to reevaluate, to reassess, and to plan a different one. But again, the family as well. The family that was coping so well at home, they are distressed. So maybe the patient situation didn't change, but we need to do something, because if we don't, this patient maybe will go to a hospital and will be admitted because of the burden of care. So an unstable phase should change very quickly. So we want the patient to move to a stable phase, or more probably to a deteriorating phase. What happens when a patient is deteriorating? We expect people in palliative care to deteriorate. We expect people with neurological conditions, neurodegenerative conditions to deteriorate. But it depends how they do deteriorate, because they can deteriorate coping with that, with symptom control, with family who are able to care for this people in that setting, or not. And so what happens when a person deteriorates? The Karnofsky changes. The Karnofsky goes down. So they need more care. Maybe you don't have to change the therapy. You don't have to change the setting of care if you are able to provide good care on that. And then, of course, you have the dying phase. David talked about the dying phase. This is so important. When we think a person is dying, well, we have to change the plan of care, because we need to be prepared for what will happen. We must be sure that we have all the therapies in case of crisis. Are we thinking this person can have shortness of breath, can be in pain, can have agitation and things like that? So all those things must be in place, because if they are not, you cannot leave that place. Okay, so it's so important to recognize the dying phase. And when a person dies, we know we haven't finished the work, because there is the bereavement that we need to assess, and maybe to refer a person that, and this is very important for neurological condition where carers maybe have looked after for years, and all of a sudden the person dies and they feel lost, and they can be at risk, for example, for themselves. And then all the things that happen around a death. So, arranging with funeral homes, technical things, and so on. So I have finished my presentation. I'm sorry that, I went probably a lot, but it was just to give you, something to think about on why it is so important to assess the needs and to measure the outcomes of our intervention. Thank you very much, and that's it.
Thank you, Simone. So we've had a lot of questions coming in, and I'm going to start with the last one first, if I may. It was to Simone. Someone's asked, can we use IPOS to assess a collective palliative care needs in a population? Could we use IPOS in a population basis?
Okay, IPOS was developed to measure palliative care needs. So if you talk about a palliative care population, of course you can. It has been done, it is validated for research. But if you think of a broad population, for example, we have quality of life measures like a SQL, for example. You can use it with the general population. You can use it with students, with healthy people. You cannot use the IPOS because the IPOS was not meant and developed for that population. So if you're talking about, so this is why I said before, you have to identify. So once you have identified a palliative care population, you can use the IPOS. Otherwise, I wouldn't recommend it at all.
And someone's just asked, how often do you use it?
Anytime we reassess a patient. So depending on the setting, of course. So if I'm a neurologist and I see the patient like 4 times per year, anytime, I identify this patient as a possible palliative care patient, anytime I have to repeat it. If I am, for example, in a hospice, maybe I do it weekly to assess the evolution of the needs in an inpatient unit like a hospice. At home, maybe we do it like every 2 weeks. But depending, if the patient is stable, I can do it monthly or maybe every 6 months. It depends on the phase of the disease, on the deterioration, and I hope I understood. I don't have too much time.
That's fine. Thank you. I'd like to come to one of the other questions that someone has asked. They work in a palliative-orientated neurological group. How do we help neurologists ask for advanced directives? She says they say they're rarely done, and ask for resuscitation status almost never done. Alexandra, as a neurologist who's been looking at advanced care planning, how do we help neurologists with this?
Well, this is a good question, and I agree with the person who made the question that neurologists rarely have these kind of conversations with their patients. And we need, I think, more training on having these, let's say, difficult conversations with our patients, and the neurologists and the caring team at the neurology center should consider dedicating time for these conversations, which cannot be embedded in the, let's say, regular conversation in which we have to discuss the therapies, the treatments, the side effects, but to dedicate an appointment to open this discussion with our patients. We cannot imagine to have all the process of an advanced care planning in a single session with our patients. It requires time, and we know as neurologists that time is a challenge in our units. So training together with a dedicated time could be helpful, I think, but this is quite important issue.
And I think as we've looked at advanced care planning more and more, it's thinking a little bit ahead. What sort of person are you? Rather than do you want resuscitation at the end of life as the first question, but what sort of person are you? Maybe easier for a neurologist to ask.
Yeah.
You like
talking
me to talk about everything.
Yeah. Sorry. Yes, we have to discuss about the patient values and priorities. So it is not just talking about prognostication. It is important, but we are the experts in terms of the disease, but in terms of illness, is the patient the expert with his own life and previous experience. So it is quite a meaningful conversation we have to have with our patients.
And the other part of that question was also, how do we inform people about post-mortem brain donation to advance research? And they were saying it's very restorative for those who do it in their families. And I think, again, it's having that confidence. Sorry, Simone.
No, I was just saying that, as I said, needs assessment tool can help in improving the quality of care. I think it also talking about values, talking about the way people like to make decisions, if they like to make decisions by themselves, if they like to be helped by families or maybe by professionals. So the way it's a way to improve the quality of care because it improves the relationship. So maybe you have in mind, I have to ask them if they want a tracheostomy or a PAG, but that's the end of it. You need to start by knowing the patient and let them understand that you are interested in that. So by doing that, you will get there. So, and I also think that when deterioration starts, when you identify a patient as possibly in palliative, with palliative care needs, that's where you have to start asking these kind of questions.
And if I can add, it is important to share also in uncertainty with our patients. We do not have to give just certainties, but if we have some uncertainties, we have to share these with our patients. It is quite important. And it needs some training, of course.
Thank you. Rahul has asked a question that we've talked about advanced care planning and that patients often change their preferences over time. Given what happens with neurological diseases, is this a concern? And what role do families play in determining choices? Perhaps if I say a little bit, as I said, there is this issue that we may only have a short period of time when we can have some of these discussions because we know that someone's going to lose their capacity with dementia or they can't communicate again very well. So that makes it difficult that we can't keep checking their preferences. But Alexandra, is there anything you would like to add?
Yeah, I think that it is also a cultural issue. Looking at advanced care planning as an opportunity and with the patients and families, not as, let's say, we are talking about this because I'm going to die tomorrow. No, this is not the issue. It is an opportunity to plan in advance with the patients, with the families, with significant others. So it is a cultural issue. I think that we have to work together to make this change.
And I think, would others agree that patients and families and professionals are often reluctant to talk about the future because they're fearful about it or don't want to give up hope or don't want to cause distress? But we have to take that. We have to, in English, we'd say bite the bullet and make and take that decision and allow people to have those discussions. Raoul asked another couple of questions, which I'm going to combine. To what extent do the management of the medical symptoms become part of the palliative medicine and palliative care team's role? And how often is the neurology professional going to be involved? If I could start, I think it is a collaboration. I will never know all the details of all the Parkinson's drug. And I would be dependent on the Parkinson's specialist to help me with that. I would hope that I may have some more expertise on helping with the discussions with planning for end of life, but I would still need to work and collaborate with the Parkinson's doctor over those areas. I don't know how the others would like to say. Simone?
Well, first of all, I think we as a European group, both with the EAPC and the EAN, are working on curriculum and are working on education because we are fully aware that there are some specific neurological issues that must be part of the training as a palliative care physician, for example. And on the other hand, we are very aware that neurologists as well need to have palliative care into their training to understand what palliative care is and how to collaborate. So that's a point we want to work, at least at a continental level, maybe, if possible, even more. But what is so important, David talked about collaboration. We don't have the ownership of the patient. None of us has it. So we have a common goal, which is to improve their quality of life, because even neurologists are fully aware that those patients who have degenerative conditions will not, heal from those conditions. So even they have to know that this is the point. So at which point do we collaborate? Well, if I don't know something, I have a telephone number and I call them. I have this, I don't know how to manage this drug or these symptoms. Do you have suggestions? And the same happen on the other hand, on the other way. So I have neurologists calling me, asking me, well, I have issues with sialorrhea, or rather than muscular spasms. They are not improving with specific neurological drugs. Can you do something for that? So this is the way so to which extent, I think we all know what symptoms are in our textbooks, the way we study them. If there's something specific, well, I will go and ask the colleague, and at the same time, I must be available to help them. So I don't know, maybe it seems silly, but that's the way it works.
Okay, thank you. Andrea has asked, what are the differences in neurological and cancer patients in dignity-related distress at the end of life? And perhaps I can answer that. I think there's similarities and differences. I think that what is different in many ways for neurological disease is the long progression and the multiple losses.
Exactly.
Of communication, of mobility, of cognition, of breathing, of autonomy, of decision-making, lots and lots of losses. And I think that adds to that existential loss and distress, which is perhaps a little different to the cancer patient who may have other losses, but they may not be quite so profound. I mean, I would recommend you read the Gofton paper, which actually is very good at explaining and discussing this. But I think there are specific things. But everyone is different. I mean, that's what's the beauty of looking after patients, that everyone is different and we have to respond to where each patient is. I don't know whether the others have anything to add to that.
Well, talking about dignity, so talking about an existential issue, very important. I think that we in palliative care have this, big luck of working together with many aspects of care. And I think, for example, the role of complementary therapy in that. So the fact that there are other therapies that can work not on the disease, but on the way the person is coping with that. So there are many complementary therapies can really help in terms of dignity, because the patient can see himself or herself from a different perspective. I'm still able to do that. I can do that. I can aim my word on that. So this is very important. Another important thing is the role of volunteers. So we have volunteers in palliative care. What do they mean? I mean, they spend their time with patients with maybe neurological conditions. And what does that mean to them? That they are important, even though they lost their possibility to move, to be autonomous and so on. They're still important because our volunteers go and want to spend time with them. So that works on the side of dignity. Okay. So I think there are many things we can do, but we need to think out of the box sometimes, not only thinking, well, we need a psychologist. The psychologist can be very important for dignity as well, but there are other aspects of care that can be involved. And neurologists sometimes might also think at palliative care because of these issues, because these are issues that maybe lead a person to ask to be hasten their death. Maybe we can help. And that's why we as palliative care, we need to be involved when someone asks a neurologist, I want to end my life. Well, before that, because we know sometimes somewhere it is possible, but before that, you should receive palliative care. This is one of the recommendations of the EAPC, because often palliative care has something that can, some bullets that can be helpful.
I have a specific one again for Simona, just to say, someone from Canada, Pavel, has said, do you use the ESAS and PPS? Okay, the ESAS is a very good tool. It was developed for cancer patients. We have, as far as I know, a PD version for Parkinson's disease. It's a very good tool, but it's very much focused on symptoms. The IPOS is more, multidimensional. The PPS is a very good tool, can be used even in neurological conditions. It includes a performance status, so it's a very good tool. There are many tools, so I'm not saying we need to use the IPOS at all. I'm just giving it as an example. But, as far as you use one and you feel comfortable with that and you measure the difference that you are doing, well, use it. Okay, so that's my point. And I think an interesting one, which I don't think we've got time to go into great depth, but someone's asked about the transition of neurology patients from pediatrics to adults, such as cerebral palsy, Duchenne's muscular dystrophy, and complex neurological problems. What can adult palliative care do to help seamless care? I'm not sure if anyone's got the answer to that. I think it's a big issue. And an increasing issue. There are more and more people looking at this. There's a couple of teams in the UK looking at Duchenne's in particular to look at palliative care for that group. But obviously the ages are increasing and increasing. I know there are many children's hospitals in the UK said, oh, we'll extend our remit until the age of 25. And now they're saying, well, most of our patients are living to 24 3/4. What are we going to do for the next stage? But I think there is a big issue about how we look after this young disabled group and young disabled who may deteriorate over the coming years. If I may say a word, David, it's even here it's a question of early intervention and collaboration. So if I have a disabled child, maybe he's 12 or 13, and I think he will survive, he will become an adult. Maybe it's there where we need to start some input and some connection, because that will make the transition easier. But you have to think ahead. We've come to the end. I'm sorry if we haven't answered your question. I have one other one I was just going to mention. How do we integrate palliative care with neurosurgery? I think discussion and talking. I hope one thing that may come from this, if you're in a palliative care unit where there is less neurology input, go and talk to your neurologist. Have a cup of coffee. Go and see them and start the conversation. the most effective way of collaboration is if you know someone. Thank you so much to everyone who's been involved. We've had an amazing number of people, and we're still at over 90. Thank you very much to Joanne and Kathy in the EAPC office who have organised this. A very big thank you to Alexandra and Simone. Just to remind you, there is the EAPC reference group. We have the website. This webinar will go on as a video, and we'll probably have another little section with the references, so you can look up references as well. We will do that. There is an email going to come round, and it was on the chat as well for feedback. And if you're interested in the reference group, come and look at the website, come and see us at the EAPC Congress, keep in touch. The AN has also got information, and now the International Neuro Palliative Care Society, which is international, has information. And finally, just to say, I don't know what to say. It's good morning to some people, good afternoon to others, good evening to some, and good night to the ones who are even further around the globe than we are. Thank you very much indeed to all of you for coming today. Good whatever it is to you. Thank you.